Hi, everyone. My name is Ibiayi Dagogo-Jack. I'm a thoracic oncologist at Mass General Hospital, and I presented ASCO highlights pertaining to metastatic non-small cell lung cancer. In particular, I would like to discuss 4 abstracts. The first one is Abstract 9005. This was presented by Dr. Deborah Bruno and is entitled Racial Disparities in Biomarker Testing and Clinical Trial Enrollment in Non-Small Cell Lung Cancer. And so this was a retrospective cohort study that analyzed the Flatiron database of about just over 12 to 1,300 patients to assess whether or not there were differences in biomarker testing, targeted therapy use in clinical trial enrollment in white and Black patients seen in largely a community setting. The study found that when the 2 racial groups were compared, Black patients were less likely to have molecular testing, including next generation sequencing. There were equal rates of targeted therapy use at about 17 to 18% in both groups. And there was low clinical trial enrollment overall, but it was 2-fold higher in white patients compared to Black patients at 4% versus 2%. So my takeaway from that particular presentation is that we need to do better in terms of molecular testing, and it's inexcusable for us to have racial disparities in molecular testing. And so there's a room for improvement all around. The second presentation that I wanted to highlight is Abstract 9006. This was a Chrysalis study, which was an updated data set, particularly for patients who had previously received Osimertinib, but had not received chemotherapy. And as a reminder, this is a combination of Amivantamab, an EGFR-MET bispecific antibody, in combination with Lazertinib, which is a 3rd-generation EGFR TKI. This study demonstrated promising activity of this combination in this population of patients with an objective response rate of around 40%, median progression-free survival around 5%. But what was interesting was the signals that they started to tease out in terms of identifying patients who might benefit most from this therapy. The authors evaluated using NGS to identify EGFR and MET dependence, as well as using immunohistochemistry. Turns out immunohistochemistry is a better gauge, and it was really able to separate patients. And so those who had immunohistochemistry expression in their tissue or expression of the EGFR MET by immunohistochemistry had a 90% response rate versus 10% in those who did not. And so we're still sorting out biomarkers for response for this particular combination, but that was a very intriguing study. The last 2 studies that I wanted to highlight, the first was Abstract 9000. This was a 2-year update from the Checkmate 9LA study. As a reminder, this particular regimen is already approved for metastatic non-small cell lung cancer, and it involves the combination of Nivo and Ipi plus chemotherapy. And so this was a 2-year update that really demonstrated ongoing kind of strong support for using this particular combination over chemotherapy, with a median PFS of around 16 months versus 11 months, and encouragingly a 12% improvement in the rate of survival at 2 years at 38 versus 26%. And this benefit was seen irrespective of PD-L1 expression and irrespective of histology. There was an intriguing signal among patients who were PD-L1 negative who had squamous tumors. I think these data are encouraging and just give us kind of additional support that this is a particularly viable regimen. But I don't know that it's significant for us to displace more commonly used regimens that involve the incorporation of pembrolizumab. The final abstract that I think is worth emphasizing, the final presentation that I think is worth emphasizing is 9002. And this is a pooled analysis from 3 Empower studies that combined atezolizumab plus chemotherapy. And this analysis assessed whether or not experiencing an immune-related adverse event predicted for better efficacy as measured by survival. And so in this pooled analysis, the authors identified that experiencing an immune-related adverse event improved survival in both patients who had received atezolizumab as well as the control group that had not. I think this leads us to kind of suspect that, that there's maybe considerable overlap in terms of the terminology and the manifestations of chemotoxicities and immune-related adverse events. Nevertheless, I think it was interesting to find that not all immune-related adverse events predicted for better benefit. Those who experience more severe immune-related adverse events defined as grade 3 or higher actually had inferior outcomes compared to chemo alone. And so this study or this abstract provides additional food for thought. I still think we have work to do in terms of identifying biomarkers or kind of the intersection between toxicity and efficacy. But I do think that these 4 abstracts or these 4 presentations are notable, and I commend the authors and the investigators for conducting these well-conducted studies and presenting these data at ASCO this year. Thank you.